And this is meant to share your experience and your thoughts and your take about the latest results of the LAAOS trial. So let's get started by this acronym. How it's complex acronym, the LAAOS trial. What is behind this acronym? Gerhard.
I think it's left atrial appendage surgical occlusion, or LAAOS, something like that.
Tom? Yeah, occlusive surgery. Yeah. And I think, and there were a couple of prior trials. So this is the reason why it's the third one. And this was the randomized trial out of the others, being preliminary.
So that's good that you start by comparing this one with the previous one, because I understand indeed, because it's the LAAOS 3, there might be two more before. So what you say is that this is distinctly, compared to the other, it's randomized, which is great because there aren't so many surgery trials which are good methodology and get to the New England Journal of Medicine. And I can see that the anchor author is Salim Youssef. So this is certainly very different from the previous one. So what is the progress from LAAOS 1 and 2 to LAAOS 3? What was the difference?
LAAOS 1 and 2 were very small trials, and they were the if I recall it right, the only randomized trials in the field, despite the fact that the surgeons are doing this procedure for decades now in the absence of any strong data. And the first LAAOS trials were just included a couple hundred of patients, so they were not powered strong enough in order to give conclusive results. And the analysis that were published from these trials, I would say 10, maybe 12 years ago, showed that there was no difference in the incidence of stroke between treated and non-treated patients.
That's wonderful. And actually, I can remember long ago, surgeons, especially during mitral surgery, was something they would eventually get and occlude the appendage. But now this has been done prospectively and properly, and we have finally an answer. So, Tom, what is the take-home message? What is the final answer from LAAOS 3?
I think the real take-home message from this trial is that among patients undergoing cardiac surgery of a variety of types, that surgical occlusion in conjunction with long-term anticoagulant therapy lowers the risk of thromboembolic events. The key thing about the patients enrolled in this trial to make that statement are that it was a broad group of individuals. They had about a fifth to a quarter of them had independent ISO-CAV or ISO valve. The others were mixed surgery procedures. So it was your classic surgical group. It wasn't specific to one or the other. And across all the different demographic, surgical, and other subgroups, the results maintained themselves, suggesting that all patients undergoing this surgery would benefit. Clearly, the patients in this particular trial had to have an elevated CHA2DS2-VASc score greater than or equal to 2, and it was 4.2 in this particular trial. But in this particular trial, the risk of thromboembolic events, the primary event outcome was, either stroke or TIA with neurological imaging confirming such, or systemic embolization. And at a 3.8-year follow-up, the differences were 4.8 versus 7.0% in the group with versus the group without. And it was statistically, significant.
So, Kurt, what was the anticoagulation strategy in the trial? Whether this was every patient was anticoagulated, or what was the strategy?
Anticoagulation was recommended for both groups, according to current guidelines. And roughly 80% of the patients in both groups received oral anticoagulation as recommended in the trial protocol. I think there are two very, very important conclusions that can be drawn from the trial. First is that the left atrial appendage exclusion that was performed in the patient is additive to oral anticoagulation. And the second is that also needs to be clearly spoken out. The trial did not investigate if left atrial appendage exclusion in these patient subset can replace oral anticoagulation. So this is something that was not investigated. That's a completely different question. But I believe that this trial will open up the next stage for clinical trials in the field of interventional left atrial appendage occlusion. Consider this: if in surgical patients there is a significant add-on benefit in anticoagulated patients by exclusion of left atrial appendage, why shouldn't it be there for patients that can be interventionally treated?
Understood. Now, is every appendage eligible for, and provided there is a high enough, CHAD score and a history of AF, but is there any anatomical, inclusion criteria whether a patient should be screened using any imaging, whatever, in order to be eligible for this therapy?
Well, I think that's actually one of the key things that comes out of this trial, Faiez. First of all, if you look at it, the ability to stay within the arm to which you were randomized, either occlusion or not, was over 95%. Number two, it appeared that there were no differences in outcomes based on that. Fortunately, there were no increase in clamp time. It was just a few minutes, and in cross time, it was just bypass time, just a few minutes. So it didn't add to the surgery, which means risk isn't higher. And if you look at the complication rate, the major adverse clinical events in terms of death, hospitalization for heart failure, rebleeding requiring going to the OR, or just bleeding alone, they were identical. So when done carefully by good surgeons in the right hands in a mixture of patients based on the type of surgery they're undergoing, there did not appear to be any contraindications. And therefore, I do not think imaging needs to be done pre-procedure, although I think there's a question about post-procedure.
Now, after a trial, everybody keeps guessing about patients who were not necessarily randomized in the trial and whether we can extrapolate or generalize the results of the trial to other trials, and certainly other patients. And patients with a score, CHA2DS2-VASc score below 2, for example, are they eligible for this sort of therapy, or we need to wait until they are randomized in such treatment?
It's a different population. I mean, Tom has explained the subset of patients that was investigated in the trial. They had a CHA2DS2-VASc score of 4.2 on average, if I recall right.
Yes.
Whether or not the same results can be expected in patients with a CHA2DS2-VASc of less than 2 is questionable to me, because the risk for an event should be substantially lower in these patients. It needs to be shown in the different trial.
I would agree with you 100%, Gert. We need a trial to address that. Having said that, I do think a lot of surgeons and referring cardiologists are going to extrapolate from this. And I think this will become common practice because of the low complication rate and the ease of doing it. So I think before this becomes mainstream and we potentially run into problems, we need to do a trial to address this issue.
So there was one more very interesting and important point. That's the question which was unanswered, or where we had conflicting results before the LAAOS 3 trial. Is there any worsening of heart failure or increased incidence in heart failure after the amputation and exclusion of left atrial appendage? There was evidence from observational studies that heart failure incidence may increase in patients with exclusion of left atrial appendage, but the LAAOS 3 trial showed that this is not the case. That gives us also another strong point in favor of the procedure.
Yes, I understand that there have been speculation that getting rid of the atrial, which is a place for producing of natriuretic peptide, may deprive patients from natriuretic peptide. But natriuretic peptide is produced everywhere in the heart and actually other places. So I don't think this is a major issue. So you have highlighted already some of the unanswered questions, and certainly patients with low CHA2DS2-VASc too. But what other next unanswered question, and what should be the other trials in this space with question not answered by LAAOS 3?
Well, I think one question, Faiez, we addressed the intraoperative one about those with lower CHA2DS2-VASc. I think another intraoperative question is, what about those individuals who have a high CHA2DS2-VASc score or have other risk factors for thromboembolic events, but have not had documented atrial fibrillation? We know that atrial fibrillation is not uncommon in these patients downstream over time. So the question is, might there be benefit to be derived from occluding the left atrial appendage in this group of patients? I think that is a key study that we need to do to determine if there is benefit there.
Okay, so now you guys are performing Watchman closure, percutaneous closures, and all sorts of interventional electrophysiology. So how does the therapy compete with what you are doing? Whether you will be, ablating more or less, or referring patients to surgeons, or keeping with percutaneous left atrial appendage closures. So what is the respective position now of the therapy as compared to percutaneous therapy?
I think one thing is clear after LAAOS 3. There is benefit for patients with high CHA2DS2-VASc score that undergo cardiac surgery for another reason and that have atrial fibrillation. That question that was open for 40 years is now answered. The two questions that I have on my to-do list, or what I would like to see list, is of course the question whether or not in which patients left atrial appendage occlusion or exclusion may be feasible to replace oral anticoagulation. That would meet a lot of the expectations from the patient side. They would accept an intervention, of course, if the anticoagulation could be taken out to improve quality of life. And the other question is, and that I addressed that before, is what we've seen in LAAOS 3 also an opportunity for percutaneous occlusion as an add-on, maybe for patients with a CHA2DS2-VASc of 4 and above? Who knows?
So let's now anticipate. I'm sure that there will be a next round of guidelines, international, and I have you both guys from both sides of the Atlantic. So how do you guess that the guidelines will evolve as a result of LAAOS 3? Let's have America first.
I think that a couple of things. Number one, in order to change the guidelines, you need very strong data, ideally multiple trials with, concordant evidence. On the flip side of the coin, when you have a strong study like this, where the evidence to me is incontrovertible, I believe this should change the guidelines. Right now, surgical left atrial appendage occlusion in both the European and the American guidelines is a class 2B indication. And in fact, the European guidelines state that anticoagulation should be continued. I don't think we should stop that right now, but I do believe we should move it up to a much higher level. And I'll pass it along to my good friend and European colleague, Gerhard, who has been very instrumental in writing the guidelines to tell us what the ESC and ACC and HRS should do.
I think it's we have exactly the same perspective, Tom. I think the guidelines will change. My recommendation after the publication of such important data is always to take a year to fully understand that, to think about that. I mean, we will discuss it at CVCT, and this is so important to digest the messages, to understand the messages, and then to transfer it into quality of care for the patients. I believe the guidelines will change. Left atrial appendage exclusion for surgical patients will become a routine procedure and a strong recommendation. I would go looking to the quality of LAAOS 3. Faiez mentioned that it's one of the best qualities that I've seen in the field of surgery. We should not forget that it's double-blinded in strategy. I would say we come pretty close to a class 1 recommendation for this patient cohort.
I agree with you, Gerhard. And I think the fact that, in the high 90% of patients adhered to the therapy to which they were randomized is really key. That's why there were no differences between, on treatment per protocol or intention to treat groups. I do think, one of the things I feel is that the guidelines and the consensus statement should be actually living documents. They oftentimes get published and then there's a long time frame before they're updated. We're beginning to see shorter term updates that do address certain issues, but I think occasionally there will be a singular issue like this that comes forward. And I think we need trialists and we need clinicians getting together to say, is the data strong enough to go forward? And it would be ideal to define what we think is going to be the data upon which those decisions were made, so that today's group isn't different than 4 years down the road when the group of writers and the group of people doing such is different. We need to morph over time, but we need to be very clear on what we're using as our criteria. So I think it should be a living document.
Yeah, well, I can't agree more. Actually, this is precisely because trialists are doing a very good job and zooming very fast. Maybe there are too speedy pace for producing new evidence, and then you need to accommodate it. And agree that waiting 3-4 years for updating guidelines may be just too long. As a final answer question, I would like to ask you a question about Cabana. Now, the surgeons have done this wonderful trial. Why Cabana didn't really meet expectations, right? It's very controversial. How what is the next step with the atrial fibrillation ablation, where we still have question marks on the strategy? It's not bound to get a class 1 recommendation, right?
Well, Cabana, I like the trial. And I don't think that if you look to the patient population that was investigated, if you look to the endpoints that has been seen, if you look to the issue that we had in Cabana with the very intense crossover between ablation and antiarrhythmic drug patients, I think at the end, and that's the bottom line, Cabana showed that catheter ablation of atrial fibrillation is safe and is effective. And if you look to the now we are leaving the randomized perspective on Cabana, but go to a more observational, but also important perspective. If you look to the on-treatment data, catheter ablation performed significantly better as antiarrhythmic drug therapy. If we look to Cabana heart failure for HFpEF and HFrEF patients, there are benefits for ablation. And last not least, the results of the EAST trial that were published last year, they also promote rhythm control strategy, a little bit of ablation and a lot with antiarrhythmic drugs in the EAST trial. Tom, how do you see that?
I see it very similarly, Gerd. I think the crossover issue was concerning because it raised a whole bunch of questions. And when trials get messy like that, it does become difficult to interpret. I think in addition to that, as we start looking at some of the subgroups of certain patient populations, like you mentioned, and we look at some of the additional data that is gained from market data, the data becomes stronger and stronger. I think one thing I've learned, though, from Cabana, and I think it was actually a good trial. It was a difficult trial to do because of physician tendencies towards referral patterns, patients' own perceptions on that, is, we have to figure out how we can do those trials better going forward. In addition to that, I think it is really, really key that we take a step back and that we realize technology changes too. And improvements in technology are going to result in, different outcomes over time too. So I think we need to look at a study, not just in the published data, but in the sub-studies and the other ancillary data that is out there. And I think looking at the subgroups of individuals who might theoretically benefit from it is also helpful in terms of quality of life, heart failure patients, et cetera. So I think we need to be, looking at it cautiously. However, to answer your question that you said earlier, I would not move the bar in terms of the guidelines based on Cabana. I would, sit tight and I would look for further things. I think it'll open up more opportunities for patients with EAST to get referred and to appropriately get done, but I wouldn't change the guidelines. Gerd, would you?
No, not at this point in time. I'm fully with you, Tom. We need more data. We need to see the publication of RAFT-AF, which has been presented at the ACC. Also an interesting trial, a little bit painful to recognize that that trial was stopped prematurely because of futility, low recruitment of patients, less endpoints than anticipated. I want to see that trial published as well. It's interesting what they describe, that the effects of catheter ablation for heart failure with reduced ejection fraction are more pronounced, with more benefits as compared to the HFpEF population. So there is more data coming up, and we need more data before we rethink about guidelines in that particular field. I completely agree, Tom.
Well, thank you so much. This has been a terrific discussion. Still, as a personal note from my side is how much clinical trial business is tricky, and certainly when there is no equipoise. And these crossovers in Cabana, and very reminiscent of what happened in ischemia as well with another domain with the interventional cardiology. This was very huge lost opportunity just because the investigators were not convinced about equipoise. They had their own biases, and they went into crossover patient, which actually deprived us from definitive answers. And I would like just to congratulate the LAAOS investigators of a terrific job. They have shown that even with surgery, you can do randomized, sham operated, and all this sophisticated methodology, which by the end of the day, get definitive answers, which are game changer, changing the practice. So thank you so much for both of you.